Our next guest is in the healthcare sector. She's a mainstay at TechCrunch, been on a bunch of our stuff, from Found to TC Live, et cetera. And we're really excited to have her because her unicorn company has completely rethought the way to bring healthcare to the communities that need it most. So please welcome to the stage Cityblock co-founder and CEO Toyin Ajayi, and your moderator, Daryl Etherington.
All right. Hello.
Hello.
Welcome.
Thank you.
Yeah, so you joined us before during the virtual Disrupt.
Indeed.
But this is your first time at the in-person. Everyone's beautiful, smiling faces.
It's so nice.
One thing Jordan mentioned there is, unicorn company. I think many times over now, right? I don't know the valuation. Last time I saw, I think it was $5.7 billion.
Thereabouts in 2021 dollars. So,
Right.
factor that all in.
Yeah, and you've raised nearly $1 billion
Correct.
now, right?
That's right.
And amazing success story for a health tech company. But how did you do that? It's probably a long answer, but how did you honestly figure out you could provide the kind of services that Cityblock provides in a way that is economically feasible and that payers and insurers will accept?
Yeah, I think the way to answer that question maybe is to just ground people on what the business is and also what the opportunity is. So we are a primary care, behavioral health, and social care company focused on low-income, marginalized populations, predominantly people who receive their insurance through Medicaid or people who get Medicaid and Medicare. So they have disabilities as well as being low income, or these are folks who are frail seniors, typically living at home in marginalized settings. And the reality is that our typical healthcare system just doesn't do a really good job of caring for these folks.
Right.
It's transactional. It doesn't engender trust. It doesn't really foster longitudinal care and access to care. And when, for so many people, as it does, the chronic compounding impact of lack of access to education, to food, to warm, safe places to sleep, to social supports, add to all of the risk factors for worsening chronic conditions, physical health and behavioral health, all of this sort of washes up on the shores of the emergency room.
Right.
So people go to the emergency room because they ran out of their insulin inhalers, rather their asthma inhalers or their insulin medication. People go to the emergency room because they're wandering the streets in psychiatric crisis because they didn't receive the care that they needed to keep them safe and in their homes. And as
It's always
we know,
crisis point.
it's always crisis, and it's expensive. And it doesn't actually solve the problem. It's sort of the definition of wasteful. And so when we looked at our model and looked at the segment of the population we really wanted to impact, we know that there are hundreds of billions of dollars a year of taxpayer money spent caring for low-income folks and for people, seniors and people with disabilities. We know that most of those funds actually pay for reactive care that is not changing the circumstances of the people's lives, does not address the root cause. And we know that health insurers have a really, really vested interest in managing that spend over time. And so when you put together sort of the market forces, a recognition that there's a failure, frankly, in the delivery system, and there's a care model that can find people, meet them in their homes, in the community, provide proactive, preventative care across physical, behavioral, and social needs, close gaps, and prevent people from having to go to the hospital in the first place. It was imminently obvious we could monetize that, right? And create a scale business that actually does things differently and solves a real problem for every single one of us. It impacts everybody in some way, shape, or form.
But so when you're talking about insurers, you're often talking about people who are very sort of those legacy businesses, right? A lot of them are massive, and inertia accounts for a lot. And also, so they're obligated in many cases to help a lot of these folks who you are addressing through Medicare and Medicaid, right? But was there a conversation ever or convincing that was required to happen when they're just well, why don't we just let a lot of these people die? Or why, it seems so heartless and cruel, but I mean, the medical system is nothing if not heartless and cruel.
It does break your heart over and over again, that's for sure. And I think that's why it's so important to both, I come to this work, I'm a physician, I'm deeply passionate about caring for underserved communities. I come to this work from a place of real heart. This is my life's work, right? And my mission. And I'm also a deep pragmatist, and I recognize that there are real economic forces that drive most of the decisions that people make in our healthcare system, certainly in the for-profit space, but also, as we read and learn more about, even in the sort of not-for-profit space, it's entirely P&L driven. And so part of what the sort of magic, I think, of Cityblock is that we have an opportunity to align what's right for humans, what I believe is moral and good, what addresses systemic issues like health disparities, the type of work that I personally would be proud to make my life's work, with a business imperative. And for these payers, there's a real business opportunity here. There's a problem they need solved, irrespective of where your sort of mission and passion is. There are folks that they are financially at risk for, they hold the insurance dollars for, who they have the opportunity to make that more viable, profitable for them by caring for them differently. And also, the regulators are recognizing that we have to sort of, like everything in the free market, it only works if you have the right balance of checks and the sort of right checks and balances around that. Regulators are pushing payers to say, we're not just asking you to hold a financial risk and do nothing.
Right.
We're asking you to actually take care of these people. So we're asking you to engage folks. We're holding you accountable for quality measurement. We're holding you accountable for access scores, for patient satisfaction scores. All of these things play into why a partnership with Cityblock is such a valuable and viable opportunity for them, above and beyond it just being the right thing to do.
Yeah, so that shift too is something I want to talk about, like the policy shift. So it's changing to a place where, I know outcomes-based care is very popular, right? And I think that's driven in part through regulatory pressure.
Yeah.
But before it was sort of like, you have to foot the bill if these folks show up and they're in crisis. But now it's become, you are responsible for outcomes throughout,
That's right.
So how much do you play in that world, in the policy world? And how do you kind of build that into the business so that you can anticipate, what's going to happen depending on changes in administration or anything else like that?
Yeah, I mean, it's sort of a push-pull, right? So our business depends on these policy tailwinds that shift towards value-based care, so getting paid for outcomes. Since we launched the company, the proportion of contracts that payers write to providers that are in these sort of value-based constructs that hold them accountable for outcomes has doubled. So now 40% of Medicaid programs are really pushing towards value-based care. And that's happened over the last 5 years. In large part,
So
I
that's
think—
spanning different administrations, right?
That's right,
With
that's
very
right.
different—
That's right,
Yeah.
different sort of political beliefs. This is something that plays, I think, across both sides of the aisle. And that's in part because there are increasingly proof points that alignment between healthcare providers and healthcare payers around the best interests and the outcomes for a population is a good thing. Certainly can't be any worse than our status quo, right? And so I think of our role in that dynamic as being one of those proof points. We help to further policy by showing what works and being willing to try new things. When the federal government comes out with demonstration programs that allow us to better impact our members, we dive in, we take advantage of that. We try to figure out how to make it work, we give feedback, and that's really important. On the other side, though, of course, there are things that play in other directions. And so understanding kind of politically and from a policy perspective where the specific states in which we partner and in which we operate are going, as well as the federal government's going, is an important part of our business. And it's just frankly the price of doing business in a sort of public sector type of space. And it allows us to just make sure we're in lockstep with the regulators.
Yeah, and speaking of, state by state, because it does vary considerably, you've just, I think over the past year, you launched in Indiana and Ohio?
Yeah,
Is that
that's right.
Okay. And then, so how hard is it for you to stand up a new market? And because it seems like you move with intention, right?
Yeah.
And you're not like, 5 states at a time or whatever. You're taking it, I don't know how many total.
We're in 7 markets now.
7,
yeah.
okay,
Yeah.
right. So how do you approach that, and how much kind of like upfront work is involved, and then what's the steady state after that?
Yeah, it takes a ton of upfront work. You've got to align a lot of things. We have to have the right policy environment that supports the type of care that we provide. There needs to be need, right? We go to communities, we try to really be humble about the way that we enter into markets. We look to see places where there are socioeconomic disparities, where there are health disparities, where there are access gaps, where we really think we can make a difference. And then we look for partners, payers, health insurers, who we can launch into markets with. And that takes some time. And then pre-launch, we spend the time, figuring out where exactly in the neighborhood should we be. Can we be near, the public transportation, near grocery stores, making sure that we're really mapping the ecosystem and showing up in places that are accessible to our members, and also positioning ourselves so we can go to the home and see people from there. And then we have to hire and recruit teams and stand up all of our facilities. So it does take a while. We're really intentional about this. This is a business that we're building to last, and that we're building to deliver on the promise of this real longitudinal care. We intend when we enter markets to be there for decades. So we're not chasing a contract and then cycling around. We're really looking to build a presence and grow. And so what you'll see is our historic markets, we grow them significantly over time. We launch with say we serve 10,000 members in a market, then we scale that. And scale that and add on as we're able to really capitalize on the benefits of our model and also the density that we then start to create within specific communities.
Yeah, and I know you talked about the holistic model, but you partner with a lot of service providers in the community, right? So what's the effect there? Do you see ecosystems built up around you when you enter new markets? Do you take on a lot of that work yourself?
I would love to see ecosystems built up around us.
You wish they were built.
I really wish there would be. Not yet.
Build them.
I love that. I love that idea. Not yet. So what we're tapping into is existing community-based organizations that provide really essential services to communities that are often very subscale, very, very local. A food pantry, a couple of shelters over here, an agency that helps people with housing or transitions from the criminal justice system. And we map together all these different networks, and then we just drive volume into those community-based providers and support them with loop closure and wraparound support so that we really become part of their ecosystem more than anything else.
Right, okay.
We think of ourselves as sort of the part of the glue within an ecosystem that knits together existing providers, the specialty providers, the hospitals, the community-based organizations, and creates this sort of seamless experience for our members, for the people whom we serve. Yeah. What's interesting is that in many ways, their business models are also kind of tenuous and vulnerable, right? And so we saw in COVID, as an example, a lot of these community-based organizations just couldn't get either the workforce to continue to come to work. They're operating on tiny margins. They're grant funded, and so sort of subjected to some of the vagaries of the grant funding cycles. And so in many ways, we have to also be prepared to just step into the gap where there is nothing. Our teams packaged up food and brought groceries to people, provided a bunch of those services and supports where there are gaps, because we're ultimately accountable for making sure that our members get what they need, irrespective of kind of what it takes to get there.
Yeah, right. Especially like you said, like if you're there for good, right? So if something goes away, but when doesn't that add a lot of like variability and unpredictability to the model, or can you kind of build that into the upfront cost? Because especially now, let's say we're going into a recession probably, right? Like I imagine that's going to get worse in a lot of cases. A lot of the funding is going to disappear from many of these organizations. How do you build that into kind of your long-term plan?
Yeah, no, it's a really good question. I mean, this is it is a complex business, no doubt, and part of the beauty of it is that we have capitation. We have these sort of resources per member per month that we're accountable for managing, and we can invest as we believe they need on a population basis to make sure that we close the gap for people. And so as long as there's a return on investment, realized really through reducing hospitalization, improving quality, improving engagement, we can make those decisions at a relatively local level that allows us to, while the business is scalable, we're really very tailored to the local environment. Right. You talked about the recession, though, and just the economic downturn and the impact that's having on people. It's going to be really interesting to see. I think more than anything, this moment in time calls for businesses like ours that are addressing folks who would get left behind otherwise. We know that the need for social supports is going to increase and has already increased. We've seen over the pandemic, through the public health emergency, the number of people on Medicaid increase. And so all of that creates for us more opportunity to prove our model, to be of value, and to demonstrate that a different way of doing this allows us actually societally to be resilient to some of these kind of exogenous challenges that we may face more broadly.
Yeah, and so you mentioned scale too, right? Like, how do you bring tech into it? Because we talked a lot about already how high touch you are, right? And you'll go to people, and you're in the communities. So what efficiencies is tech providing, and why is that an essential part of the model?
Yeah, it's key. So tech plays a number of roles for our business. The first is in data, understanding what to do for whom, in sort of what dose even, is really nuanced and really important. It's a great application for data science, and a really, really useful application for the technology tools that we've built in-house to direct our team. So I have a population of individuals that includes some young folks, some older folks, some folks with disabilities, some folks with mental health challenges. I have to engage all of them. Who do I go after first?
Right.
Who do I call first? Who's gonna go to the emergency room tomorrow unless they get a phone call from us? Who's not home today because they're likely out working, or who's likely to be engageable on the weekend? Those are types of things that we can use our data and our data products to help us better refine. So we're able to get to our folks as quickly as possible, right modality, right time, and earn their trust. The next thing is then, what do you do for them?
Yeah.
If a person has a multitude of challenges, like many of the folks we care for, what's the most important unlock for them? We know for folks who are living on the streets or who are marginally housed, who are unhoused, that almost before you do anything else, you've got to get them a safe place to sleep, right? So there's no point saying, I'm going to titrate your insulin, I'm going to write a new prescription for X or Y, I'm going to make a referral to Z, if they literally have no place to sleep.
Right.
That's more obvious. You can sort of build that in, but there are nuances to all of the interventions that we deploy, spanning across community health workers, social workers, behavioral health, primary care, acute care, and understanding the right dose, right time is another really important application of our tooling. And then it allows us to really direct workflow management tools, because now you've got folks, our members, people who we care for, who are engaging in our mental health services, or engaging in our primary care services, or engaging in our at-home urgent care services. Make sure everybody's on the same page.
Right.
We all know what the care plan is. We know what's going on for them. We know what matters to them. We know that they like to be called Mike and not Michael. That stuff really matters.
Yeah.
Where do you house that information to allow and enable that trusted longitudinal relationship across which we're deploying clinical interventions and social interventions?
Yeah.
And that's the role of technology for us.
Yeah, when you talk about that, like, it becomes apparent in retrospect how many things happen wrong because most care is acute and most care is fracture, right?
That's right.
So
It's not coordinated at all.
Yeah.
And it's duplicative, it's costly, and it's abrasive to
Yeah,
people.
yeah.
When we interview our members about what they dislike about the traditional healthcare system, it's like, I got to tell my whole story over and over again.
Right.
And then you add on the layers of discrimination and stigma that many people face. More than half of our members are people of color, because that's the sort of representation of Medicaid and dually eligible populations. I have a mental illness, for folks, they go in there and they say, well, are they going to treat me badly because they know I have bipolar disorder? And so telling your story over and over again seems benign. But a healthcare system that makes people tell their story over again actually subjects them to friction, abrasion, sometimes even trauma,
Right, yeah.
that is entirely counterproductive to a therapeutic relationship that's going to result in better health outcomes, right?
Yeah.
And so even alleviating that is such a meaningful lever for us, and it's part of the way that we're able to really ground our care in that trusted relationship and earn the trust of our members.
Yeah. So I have to ask then back to the ecosystem question, because you mentioned you would like that to happen, and it seems like population level analytics would unlock so much for potential partners or services that address other gaps that you see. So how much do you think about that? What would you like to see kind of prop up, and are you open to kind of data sharing, anonymized or whatever, but population level?
Oh my gosh, it's like music to my ears. We'd love to see that. I mean, we are at a community level struggling even on basic things like, our health information exchanges, right? Those are supposed to be publicly available, at least accessible to healthcare providers, repositories of who gets admitted to the hospital, when, for what diagnosis, who gets discharged, when, for what. And the coverage of these things, they're so variable from state to state. The sort of loopholes and challenges and gaps in those data, it's profound. And so a solution that solved that would be critical, but you can't get around that without thinking about interoperability. And so we've got these massive hegemonic electronic health records,
Right.
whose entire business is predicated on not sharing data, because their data is their wedge and their moat. They have no incentive to share, and there's no obligation for them to do so. So there's all this data locked up in places that no one can access it, and it's entirely to the detriment of all of us, consumers, patients, but particularly people with complex needs who are touching the healthcare system so frequently.
Yeah. So, but once you have your data trove, do you see it as a valuable resource to be defended, or do investors perhaps pressure you to do that, right? Because you can see how that would be like, well, we've put a lot of money in here, and this is quite valuable, and maybe we want to turn that around into something.
I mean, I think that we're not sort of in the business of monetizing our data at all, and that's certainly not a conversation we're having. I think that the question for me is to whom, to what end, and can you do it safely and legally, you know? And there's a lot of like appropriately real protections around people's data that I think are absolutely right. I think you can't do this on a one-off basis absent a big like ecosystem infrastructure, really strong policy, regulatory guidance to make sure it is safe, and of course, like opt-in consent and opt-out abilities for patients whose data it actually is. So this is not one of those where we could be like, we believe this, and we're just going to make it happen. Here's our data.
Right.
That's dangerous, and would certainly get us into a lot of trouble, and certainly would undermine the trust that we're seeking to build with our members. But if there was a real concerted, and I think it has to be like at the federal level, real policy effort to make this possible, and sort of, you know, an obligation for all players to play together, I would welcome that. And I think, again, if done well, I think consumers and patients would really benefit from it.
Yeah. So I have to ask the obligatory Canadian question, which is...
Do I want to move to Canada?
Not that. I mean, it's a nice place. But I think, so policy, whenever I talk to people in the healthcare industry, right, I ask about like, would you rather do more fundamental policy change or whatever? Like, would you rather switch to a socialized care model? If you had your way, you could wave a magic wand and have whatever, or would you rather work with the way you are now, with the for-profit and doing, you know?
Yeah, I mean, it's such a difficult, we can answer the question.
It's magical thinking,
It's magical thinking, wave a magic wand.
Yeah.
Like, do I believe that healthcare is a right that should be available to all people, irrespective of their ability to pay, and that it should be distributed equitably? Yes, 100%. Right. I think there are a lot of, like, absolutely. And there are a lot of ways of achieving that. Our system is not set up for that to be the default outcome.
Right.
So like, would I pick this if I had a magic wand to design a healthcare system that leaves people behind desperately every single day? A healthcare system that says that someone like me, who looks like me, just by virtue of my race, has a 3 to 6 times more likely chance of dying in pregnancy because of systemic factors, because of a completely unchecked racism in our system and our society and our healthcare system, because of stigma, because of lack of equitable access to services, like absolutely not. And here we are. And so like, what do? You know, you sit at the sidelines, you complain, you picket, you demonstrate.
You create a trickle-down model?
We do not do that.
Let's throw back to last year, if people want to watch the
Certainly
video.
don't do that. But we pick ourselves up together and we say, we're building a movement that believes that it is still possible to do things better and differently, and like refuses to accept the status quo, just refuses to. And for me, that's what Cityblock is about, but frankly, that's what this movement that I think we've been certainly a part of helping to stimulate has been about, is to say, hey folks, like, stop. This isn't working for a lot of people.
Yeah.
They're not represented in this room, but we have to bring their voices into these conversations. We have to build for them, because it's unacceptable. It's unacceptable in 2022 that we're looking at exactly the same data that we were looking at 15 years ago about healthcare disparities, healthcare outcomes, all exacerbated by COVID. Everyone's like, oh my God, Black and brown people are dying more from COVID. Oh my God, poor people are dying more from COVID. Oh my God, like essential workers who don't have health insurance are dying. We knew this stuff.
Right.
Like, give me a break. So, yes.
Yes.
I would very much have designed it differently.
Yeah.
And I'm also not content to bitch and moan about it.
Right.
We got to do something.
No, and this is the system you have, right? And
Make it work better.
And you're speaking the language of the system you have, right?
That's right.
You're dollars and cents, and it's working.
Yeah.
I think you're doing a great job, and thanks very much for being here with us and coming out to Disrupt.
Thank you for having me. I always love talking with you.
It's great. It's great. We're actually buddies.
We are really buddies. Thank you. Thanks, everybody.